You brush, you floss, you use that minty mouthwash every night, and still, someone tells you your breath is a problem. Before you blame yourself or buy every new product on the shelf, pause. One of the most common causes people miss isn't in your mouth at all. Chronic sinus inflammation and postnasal drainage can quietly seed bad breath, hiding behind the nose, where routine oral care barely reaches. In the next few minutes, you'll learn how to check the 3 most likely reservoirs that produce noticeable odor, what a quick 48-hour targeted trial looks like, and how to read the results so you know whether to see a dentist, a periodontist, or an ENT. If this speaks to you, type 1 in the comments and hit subscribe so you don't miss the hands-on demo we show in detail later. Let's start with the core mechanism, because understanding how the smell forms helps you know where to look. Breath odor isn't magic. It's chemistry. When bacteria break down protein-rich debris in the mouth or upper airway, they produce volatile sulfur compounds, or VSCs. Those are the molecules that often smell like rotten eggs or a sulfurous note. The same family of bacteria can live on the back of the tongue, in periodontal pockets around teeth, in tonsil crypts, and along the mucous lining of the nasal passages and sinuses. Where the bacteria live, the reservoir, shapes both the character of the smell and the kind of treatment that will help. If the rot comes from the tongue's surface, you'll typically notice a sulfurous tang that reduces after tongue cleaning or a strong mouthwash. If the odor is coming from deep periodontal pockets, you may notice a persistent musty smell that returns within hours of brushing and often accompanies bleeding on flossing or loose teeth. Tonsil stones create a focal, sometimes very sulfurous smell that you can sometimes see as small white or yellow pebbles in the tonsil crypts. Sinus and postnasal sources are often less obvious. You might not see anything in your mouth, but you'll have chronic throat clearing, a sensation of mucus dripping down the back of your throat, or a lingering bad breath even after careful oral hygiene. The trick is to identify which of these reservoirs is most active for you, and you can do that with 3 rapid self-checks that take under 2 minutes. First, the tongue scrape and smell test. Use a clean tongue scraper or the back edge of a clean spoon. Stand in front of a mirror with good light. Extend your tongue and gently scrape from the back toward the front. Don't force it into the deep throat. You only need to reach the posterior third of the tongue surface where coating commonly accumulates. After 1 or 2 scrapes, place the scraped material into a small disposable tissue or on the scraper and take a cautious sniff from a short distance. If there is a sulfurous odor on the scraper or tissue, the tongue is likely a major contributor.
Note the color and thickness of the coating. Thin, slightly white film responds quickly to consistent care. Thick, yellowish, or greenish biofilm suggests a heavier microbial load that may need more sustained attention. Second, the gauze or floss smell test. Using a fresh piece of sterile gauze or unwaxed dental floss, gently rub along the gum line of your back molars and then smell the gauze or floss. Be thorough but gentle. You're testing the area where food debris and plaque accumulate around the tooth restoration interface and where periodontal pockets tend to harbor bacteria. If this test yields a strong malodor, or if you notice blood on the floss, that points to periodontal disease or poorly fitting restorations as the likely source. Both of those are clinical problems that usually require professional treatment beyond home care, but the test helps prioritize the next step. Third, the mirror tonsil check. In a well-lit room, open wide and use a small flashlight or the mirror's light to look at the back of your throat. Tilt your head forward and say "ah" to lower the tongue enough to see the tonsils. Look for small white or yellow pebbles tucked in the crypts of the tonsils. Those are tonsilloliths or tonsil stones. If you see them, don't reach for a fingernail, toothpick, or any sharp instrument. Note whether the stones are large and numerous or small and intermittent, and whether you feel a lump at the back of the throat or have frequent bad breath after waking. Visible stones often respond to conservative measures like saline gargles and increased hydration. Persistent, symptomatic stones are an ENT conversation. With those checks complete, you already have a better sense of where to focus, but isolated tests only tell part of the story. That's why a structured, time-limited trial, a focused 48-hour routine is so useful. It's short enough to fit into your week and long enough to give you meaningful feedback. The goal is not to promise a cure. The goal is to reduce the activity of likely reservoirs and watch what changes. Keep a simple log, morning and evening entries noting whether breath improved, whether tongue coating reduced, whether you saw blood on floss, and whether postnasal tip got better or worse. Record subjective smell intensity on a 0 to 5 scale, and any throat clearing or cough. Here's a clinician-framed 48-hour routine to try. Morning and evening, brush teeth thoroughly with fluoride toothpaste and spend at least 45 to 60 seconds brushing the tongue gently, followed by scraping the posterior tongue once or twice with a clean instrument. Floss or use interdental brushes once daily, focusing on back molars where plaque can be deep. Rinse with an alcohol-free antimicrobial mouthwash once daily if tolerated to reduce planktonic bacteria, but avoid long-term unsupervised use of strong antiseptics. After meals, rinse with plain water and consider a xylitol-containing gum to stimulate saliva and help clear debris.
Twice a day, perform a gentle saline gargle. A warm saltwater swish and gargle for 15 to 20 seconds helps dislodge tonsillar debris and soothe inflamed tissues. If you suspect postnasal drip, add a saline nasal irrigation once daily using distilled or previously boiled then cooled water, and follow product instructions closely. Nasal saline decreases mucus stasis, which reduces the food source for odor-producing bacteria. Keep hydrated and avoid prolonged mouth-drying activities like heavy caffeine or antihistamine use without clinician guidance. If you use prescription medications for chronic conditions, continue them unless your clinician advises otherwise. Do not stop on your own. Throughout these 48 hours, watch for immediate clues. If tongue scraping materially reduces the odor within hours and the scraped material smells strongly but improves with each use, the tongue is likely your main target. If the gauze floss test remains strongly malodorous despite improved tongue cleanliness, or if you see blood on the floss, that points to periodontal disease or a problematic restoration. Time to see a dentist or periodontist. If oral tests are negative but you have persistent throat clearing, postnasal drip, nasal congestion, or a sensation of mucus in the back of your throat, the sinuses are the leading suspect, and ENT evaluation should be next. 2 days won't fix complex periodontitis, chronic sinus disease, or advanced tonsillolith problems, but it will give you a practical signal to guide the next step. Interpreting results requires nuance. A marked improvement after tongue-focused care suggests that consistent tongue hygiene plus improved salivary flow and hydration is likely to control the problem in the short term. We typically see tangible change within days when the tongue is the dominant issue. Continued improvement over 2 weeks is a good sign. A modest or absent response with strong signs on the gauze floss test suggests deeper oral disease. Periodontal pockets shelter anaerobic bacteria that produce VSCs. These bacteria are not eliminated by brushing or mouthwash alone and usually require professional debridement, improved home care, and sometimes periodontal therapy over several weeks to months. Visible tonsil stones that persist despite conservative measures may need ENT assessment. Small stones often respond to non-invasive care, but large or recurrent stones can require office removal or, rarely, surgical options, which your ENT will explain alongside risks and benefits. Finally, a negative oral exam coupled with ongoing symptoms of nasal obstruction, postnasal drip, or nasal discharge raises the likelihood of chronic sinusitis or rhinitis. In those cases, ENT assessment that may include nasal endoscopy or imaging is the appropriate next step. To make this practical, let me give you a few patient examples, composite vignettes that mirror what clinicians see and how a focused plan plays out.
Anna is a woman in her 30s who brushes and flosses daily but wakes with bad breath and a visibly coated tongue. She reports a dry mouth at night and occasional gum bleeding after flossing. On the first day of the 48-hour trial, Anna scrapes her tongue each morning and evening, increases her water intake, and uses xylitol gum after meals. By the end of the second day, she notices less coating on the scraper and a softer smell overall. Her log shows a drop from a 4 to a 2 on the subjective scale. For Anna, the working hypothesis becomes tongue coating, with possible mild gingivitis. The plan: continue improved tongue hygiene for 2 weeks, schedule a dental cleaning, and reassess. If improvements plateau, her dentist will evaluate for plaque control issues or medications contributing to dry mouth. Marcus is in his late 40s. He has a history of bleeding gums and a loose lower molar after years of inadequate dental care. His gauze test yields a persistent, foul odor, and flossing returns blood consistently. Marcus's 48-hour trial improves his breath minimally. The likely driver here is periodontal disease. A dentist or periodontist visit is warranted for probing, cleaning below the gum line, and a plan for scaling and root planing. In Marcus's case, professional therapy over several weeks is likely necessary, with expectation of gradual odor reduction as pockets heal and the bacterial load decreases. Leah is a school teacher who has battled seasonal allergies and chronic nasal congestion for years. Her oral tests are unremarkable. Tongue scrape is mildly positive, but gauze is not malodorous, and there are no visible tonsil stones. However, she reports constant throat clearing and the sensation that mucus pools in the back of her throat. After the 48-hour trial that includes saline nasal irrigation and nightly nasal steroid as previously prescribed by her PCP, Leah notes decreased throat clearing and an improvement in perceived breath freshness. For Leah, the sinuses were the likely chief contributor. Her next step is an ENT appointment to assess for chronic rhinosinusitis, nasal polyps, or allergic rhinitis that may require targeted therapy beyond saline and steroids. A separate vignette involves a patient who discovered large tonsil stones. On mirror inspection, they saw several firm, pale stones lodged in the tonsil crypts. They followed conservative care, frequent saline gargles, increased hydration, and a short-term increase in oral hygiene vigilance. Some stones dislodged spontaneously or softened with gargling. The patient was advised not to attempt sharp, forceful home extractions due to bleeding and infection risk. When symptoms persisted and stones recurred, an ENT performed an in-office removal and discussed cryptolysis as an option to reduce the likelihood of recurrence. This illustrates the escalation ladder. Start conservatively, document response, then partner with an ENT if stones are recurrent and symptomatic.
These vignettes also point to an important mindset shift. Halitosis is usually multifactorial. More than one reservoir can contribute simultaneously. A patient can have a coated tongue plus mild sinus drainage, or periodontal pockets alongside intermittent tonsil stones. That's why a methodical, time-limited trial paired with clear documentation is so helpful. It tells you and your clinician which tracks to follow without guesswork. Now, let's expand the rationale behind some of the home measures in the 48-hour plan so you understand why they're chosen. Tongue scraping and mechanical cleaning physically remove the adherent biofilm and the substrate bacteria feed on. Saline gargles create a hypertonic environment that helps dislodge debris and change the local environment for bacteria. Xylitol-containing gum isn't a cure, but as a saliva stimulator, it helps clear loose debris and increases saliva's natural antimicrobial actions. Alcohol-free mouthwashes reduce transient planktonic bacteria without causing the mucosal dryness associated with alcohol-based rinses. Still, long-term reliance on potent antiseptics is not advised without dental supervision because they can alter the oral microbiome and mask underlying disease. Saline nasal irrigation reduces mucus stasis in the nasal cavity and nasopharynx, decreasing the food source and substrate for odor-producing microbes in the upper airway. For any nasal irrigation, use distilled or boiled then cooled water and follow device instructions to reduce risk of infection. In your log, note not just smell intensity, but also objective signs. Is there blood on floss? Is the tongue coating thick or thin? Is there visible discharge in the back of the throat? Are you coughing or clearing your throat frequently? Did you sleep well or did you wake with dry mouth? These small details matter when you speak to a clinician. If you see blood or experience severe pain, worsening swelling, fever, or difficulty breathing, those are red flags that require prompt medical evaluation rather than a home trial. At the same time, keep expectations realistic. If periodontal disease is the main problem, 2 days of improved hygiene is unlikely to solve it. Improvement often takes multiple professional cleanings and weeks of healing. If you have chronic rhinosinusitis, inflammation of the sinonasal mucosa that persists beyond simple seasonal allergies, you may need targeted topical steroids, a longer course of nasal irrigation, or further ENT assessment with nasal endoscopy and irriging. Endoscopy is a flexible, lighted examination that allows an ENT to visualize the nasal cavity and nasopharynx directly. CT imaging provides a non-invasive map of sinus anatomy and chronic disease. These are clinician-delivered diagnostics. They are useful when your 48-hour and 2-week trials show persistent symptoms, or when ENT signs are present.
Before we go deeper into the specifics of oral, tonsillar, and sinonasal pathology, let's walk through what a clear, concise conversation with a clinician looks like after your trial. Prepare to bring your log. A good opening line to a dentist or periodontist might be, "I completed a 48-hour targeted routine to isolate the source of persistent bad breath. My tongue scraping improved smell slightly, but floss or gauze from the lower molar area remained malodorous, and there was bleeding on floss. I'd like a periodontal evaluation with probing depths and a treatment plan." To an ENT, you could say, "I've done at-home oral checks and a 48-hour trial without meaningful improvement. I continue to have postnasal drip and throat clearing. I'd like an evaluation for chronic sinusitis, including nasal endoscopy and consideration of imaging." For your PCP, succinctly document medication lists and systemic symptoms. "My bad breath persists despite oral care. I have dry mouth on some medications and intermittent reflux symptoms. Could we review meds and consider screening labs if indicated?" These scripts save time and direct the clinician to perform the appropriate tests. We've now covered initial detection, the short 48-hour trial, and how to interpret early results. The next deep dive is to examine oral sources in greater clinical detail, how tongue coatings form at a microscopic level, why periodontal pockets act as anaerobic reservoirs, and how poorly fitting dental restorations trap odor-producing debris. But before we move into those microscale discussions, it's helpful to pause on tonsils and sinuses, because they're often the overlooked players behind persistent halitosis. Tonsil crypts are natural indentations in the tonsillar tissue, where debris, food particles, mucus, dead cells, can accumulate and calcify into small stones.
The stones themselves are rich in bacteria and sulfurous compounds and can cause a focal bad odor. Conservative care emphasizes non-invasive measures: saline gargles after meals, staying well hydrated, chewing sugar-free gum to increase saliva flow, and gentle mechanical rinsing. Recurrent symptomatic stones may be evaluated by an ENT, who can remove them in office, apply procedures to reduce crypt size, cryptolysis, or in rare and selected cases discuss tonsillectomy. All of these options carry trade-offs that an ENT will review in the context of your symptoms and overall health. Sinus-related odor is more subtle, but often underappreciated. Chronic rhinosinusitis and allergic rhinitis create a milieu where mucus is produced continuously and drips down the back of the throat. This mucus contains proteins and trapped microbes. As it accumulates on the posterior tongue and pharynx, it becomes food for anaerobic bacteria that produce VSCs. The smell may not respond well to oral measures alone because the reservoir is upstream in the nasal cavity and sinuses.
Medical strategies aimed at reducing mucus production and improving drainage, saline irrigations, topical nasal steroids, antihistamine strategies for allergic contributors, and targeted antibiotics only when bacterial infection is suspected, address the underlying mechanism rather than only masking the odor. An ENT can assess the nasal passages directly with endoscopy. They may also recommend imaging if anatomic factors such as narrow drainage pathways or polyps are suspected. Treatment timelines vary. Some patients see improvement within days to weeks with medical therapy, while others with structural disease may need procedural interventions to restore drainage and long-term improvement. At this point, you should have a solid toolkit for immediate action: the 3 quick checks to narrow the likely reservoir, a 48-hour clinician-framed trial to gather data, and a plan for how to present findings to the appropriate clinician. What we haven't yet covered in depth are the biological nuances behind tongue biofilm maturation, the specifics of periodontal therapy timelines, detailed ENT diagnostic algorithms, and how systemic conditions like metabolic disease or medication-induced dry mouth fit into the differential. We're about to unpack those next, diving into cellular behavior on the tongue surface, the role of anaerobic biofilm communities in periodontal pockets, the safety considerations and expectations for tonsil-directed interventions, and the stepwise ENT approach to chronic rhinosinusitis, including when imaging and endoscopy add crucial diagnostic clarity. Each of those sections will give you further practical actions, more sample clinic scripts for conversations with doctors, and an extended FAQ to address common concerns. We left off with the promise to dig deeper into the biological mechanics, the clinical pathways, and the practical scripts you can bring to appointments. Let's pick up there and walk through each domain step by step so you understand what's happening, what to expect over time, and how to move from a home trial to a confident conversation with a clinician. Start with the tongue. The visible white or yellow coating you see on the back of the tongue is not just dead food. It is a complex biofilm, a community of microbes embedded in a sticky extracellular matrix. The posterior dorsal tongue has irregular papillae and a relatively low shear environment, less saliva flow and mechanical abrasion, so bacteria and debris adhere more readily. Protein-rich substrates from food, postnasal secretions, and shed cells provide fuel for anaerobic bacteria that produce volatile sulfur compounds, or VSCs. Removing this biofilm mechanically by scraping or brushing reduces the bulk of substrate quickly and lowers VSC output, but biofilms can reestablish if underlying contributors remain: dry mouth, mouth breathing, high-protein diets, smoking, or ongoing postnasal drainage.
For many people, consistent mechanical cleaning twice daily, plus hydration and saliva stimulation, produces measurable improvement within days. For others, improvements accumulate over weeks because the biofilm community takes time to shift toward a less odor-forming composition. Practical implications: be consistent. A single aggressive scrape may reduce odor briefly, but will not reset an entrenched biofilm. For persistent cases, the 48-hour trial will show an early signal. If odor falls substantially within 2 days and keeps improving over 2 weeks, the tongue is likely dominant. If improvements stall despite strict tongue care, look elsewhere. Next, periodontal pockets. Periodontal disease creates true pockets, spaces between tooth and gum where oxygen is limited and anaerobic bacteria thrive. These pockets shelter bacteria that are hard to reach with routine brushing and standard rinses. The gauze/floss smell test aims to detect these reservoirs by sampling right where plaque and subgingival debris concentrate. When pockets are present, you'll often see bleeding on probing or on floss, gum recession, loose teeth, or persistent bad taste that does not respond much to tongue cleaning.
The clinical pathway for periodontal-driven halitosis usually involves professional debridement, scaling and root planing to remove subgingival calculus and biofilm, combined with an individualized home care plan, interdental brushes, improved flossing technique, possibly a medicated rinse for short-term use under dental supervision. Healing of pockets and a reduction in odor typically occur over weeks to months, not days. The clinician may measure pocket depths with a periodontal probe, chart bleeding on probing, and take radiographs to evaluate bone levels. If pockets are deep or recurrent despite therapy, referral to or consultation with a periodontist is appropriate. Periodontal therapy reduces the anaerobic load and often produces a steady decline in odor as the tissue heals. Poorly fitting restorations, over-contoured crowns, and open margins trap food and plaque. These are less dramatic to see, but a small localized odor that persists despite a clean tongue often points to a restoration problem. A dentist will check margins, contour, and contact points. Corrective replacement or adjustment of the restoration can resolve the pocket that is feeding the smelly bacteria. Tonsil stones deserve a closer look because they bridge otolaryngology and self-care. Tonsillar crypts are folds and pits in tonsil tissue. They provide small pockets where debris, dead cells, mucus, and bacteria accumulate and occasionally calcify into tonsilloliths. Tonsil stones are most common in people with deep tonsillar crypts or chronic inflammation of the tonsils. They can produce a focal, pungent odor because they concentrate anaerobes and their metabolic byproducts. Conservative measures for tonsil stones are safe and effective for many people.
Regular saline gargling after meals loosens debris and flushes the crypts. Increasing hydration and chewing sugar-free gum can help keep saliva flowing and clear loose debris. Good overall oral hygiene reduces the surrounding bacterial load that might seed the tonsils. If a stone is visible and small, gentle gargling or allowing it to come out on its own is the safest route. Never use sharp tools to pry or dig at tonsils. That risks bleeding and infection. If stones are large, recurrent, or cause ongoing symptoms like a persistent foul odor, gagging, or discomfort, ENT evaluation is appropriate. ENT options include in-office removal under direct visual control, cryptolysis, procedures that reduce the depth of crypts, or in selected and rare cases with significant symptoms and failed conservative measures, tonsillectomy. Each option has trade-offs. Cryptolysis may reduce recurrence for some patients without the morbidity of removing the entire tonsil, while tonsillectomy is definitive but involves surgical risks and recovery. An ENT will discuss these with you and tailor recommendations to symptom severity and your overall health. Sinus and postnasal drip mechanics require careful emphasis because these are frequently overlooked. The sinonasal mucosa produces mucus as part of normal airway defense. When inflammation from chronic rhinosinusitis, allergic rhinitis, environmental irritants, or anatomic narrowing impairs mucociliary clearance, mucus pools in the nasal cavity and drains posteriorly into the nasopharynx. That mucus contains proteins and trapped microbes. As it sits on the posterior tongue and pharyngeal mucosa, it supplies substrates for anaerobic bacteria to generate VSCs. Unlike a tongue coating you can scrape directly, this reservoir is upstream and less responsive to oral measures alone. Key ENT diagnostics, nasal endoscopy and selectively sinus CT. Nasal endoscopy is an office-based exam using a flexible or rigid endoscopy to visualize the nasal cavity, middle meatus, and nasopharynx. It can identify mucopurulent drainage, polyps, edematous mucosa, or anatomical blockages to drainage. CT imaging provides detailed anatomy and helps plan interventions when chronic disease or structural obstruction is suspected. Neither test is a first-line step in routine mild cases. They are used when the history or initial trial suggests persistent sinonasal disease, persistent congestion, purulent nasal discharge, significant postnasal drip, or lack of response to a proper medical trial. Medical management of sinonasal contributors focuses on reducing inflammation, improving drainage, and addressing allergic drivers when present. Saline irrigations, daily or twice daily, using distilled or correctly prepared water, physically wash mucus and reduce stasis. Intranasal corticosteroid sprays reduce mucosal inflammation over days to weeks and are a cornerstone for allergic and chronic inflammatory disease.
Antihistamines are useful when allergic contribution is significant, but sedating antihistamines can worsen mouth dryness and counteract benefits. Short antibiotic courses are reserved for cases where bacterial infection is suspected, and evidence supports that approach, not as a blanket remedy for odor. For selected patients, topical agents such as nasal steroid irrigations or rinses, delivered by certain devices, can provide better mucosal contact than sprays.
When structural disease, polyps, significant anatomic obstruction, or persistent localized infection is present, ENT procedures to improve drainage may be indicated. These are clinician-managed decisions that balance symptom burden, imaging, and risk. Expectations for sinus-related improvement vary. Some patients notice symptom relief and reduced odor within days to weeks of consistent medical therapy. Others with structural disease may need procedural intervention and a longer recovery period for durable change. Systemic causes deserve a careful scan because they are less common but important not to miss. Certain metabolic states create characteristic breath changes. Ketosis from low-carbohydrate diets or prolonged fasting produces a fruity/acetone odor that is distinct from sulfurous VSC smell. Renal failure and uremia can cause ammonia-like breath, while advanced liver disease can create musty or sweet odors due to impaired detoxification. Gastroesophageal reflux disease, GERD, can bathe the oropharynx in gastric contents, altering local pH and bacterial ecology and sometimes causing a persistent bad taste or odor. Many medications cause dry mouth: anticholinergics, certain antihypertensives, tricyclics, some antidepressants, which reduces saliva's mechanical and antimicrobial function and promotes biofilm formation. If your trial shows overall improvement in oral hygiene practices, yet persistent odor, or if you have systemic symptoms, fatigue, change in appetite, significant weight change, swelling, or abnormal urine, involve your primary care clinician for medication review and targeted labs. Blood tests might include metabolic panels, renal function, liver tests, and rarely more specialized endocrine or metabolic testing depending on the clinical story. Now a practical escalation ladder once again, but with specific timelines and reasonable expectations for improvement. Tongue-dominant sources expect measurable improvement within 48 hours to a week with disciplined mechanical cleaning, hydration, and saliva stimulation. Continued improvement over 2 weeks with maintenance thereafter. Tonsil stones, conservative. Small stones may resolve within days of consistent saline gargling and hydration. Recurrent or large stones may need ENT review within 2 to 6 weeks if symptoms persist. Periodontal disease. Expect a slow decline in odor over weeks to months after professional debridement and improved home care. Follow-up probing and reassessment at 4 to 12 weeks is common.
Chronic rhinosinusitis. Some patients improve within days to weeks on medical therapy, saline irrigations, intranasal steroids, but those with structural disease may take longer and sometimes need procedural intervention. ENT evaluation is appropriate when symptoms persist after an initial 48-hour to 2-week home effort, especially if nasal symptoms dominate. Systemic contributors. Timelines depend on the cause. Medication adjustments or treating metabolic disease may influence breath in days to weeks, but overall management follows the underlying diagnosis. To make this tangible, here are expanded follow-ups on our earlier vignettes, showing clinician interactions and timelines. Anna, follow-up. After her 48-hour signal suggested tongue-dominant odor, she continued with strict tongue scraping twice daily, used xylitol gum after meals, and scheduled a dental cleaning. Her dentist confirmed mild gingivitis but no deep pockets. After 2 weeks, Anna's log showed a steady fall from 4 to 1. She maintained a daily tongue scrape and intermittent saline gargles, and her perceived social confidence improved. Her dentist recommended periodic maintenance cleanings and a short review of her nighttime medications for dry mouth. Nothing was changed with coordination with her PCP. Marcus, follow-up. Marcus's bad breath was driven predominantly by periodontitis. After initial dental evaluation with charted pocket depths averaging 6 to 7 millimeters in his lower posterior teeth, he underwent scaling and root planing over 2 visits. He used interdental brushes, improved brushing, and returned for reevaluation at 6 weeks. Gradual reduction in pocket depth and bleeding correlated with a progressive improvement in odor. After 3 months, his subjective breath score fell from 5 to 2, and his dentist discussed a long-term periodontal maintenance plan. Leah, follow-up. Leah's ENT referral included nasal endoscopy, which showed bulky inferior turbinates and moderate mucopurulin drainage consistent with chronic rhinitis and secondary sinus inflammation. Her ENT started daily saline irrigation and optimized a topical steroid regimen. After 4 weeks, she reported less throat clearing and improved breath. The ENT emphasized ongoing nasal hygiene and offered allergen testing as a second step if symptoms recurred seasonally. Tonsil stone patient follow-up. The patient with recurrent symptomatic tonsilliths attempted aggressive conservative care for 8 weeks with frequent gargles and improved hygiene, but continued to have large symptomatic stones that interfered with swallowing and social comfort. ENT removed the stones in office under local anesthesia and discussed cryptolysis as an option to reduce recurrence. The patient chose cryptolysis after discussing risks and benefits, and at 6 months reported fewer recurrences and improved quality of life.
This underscores that ENT procedures are effective options when conservative measures fail and symptoms are significant. To make your clinic communication precise and effective, here are verbatim scripts you can copy, personalize, and bring with you.
These are written in a clinician-friendly, concise format that makes it easier for your dentist, ENT, or PCP to act on your concerns. For the dentist or periodontist, I completed a structured 48-hour oral sinus trial to identify the source of persistent malodor. Tongue scraping reduced odor somewhat, but gauze/floss sampling at the lower right molars remained malodorous and produced bleeding on floss. I'm concerned about periodontal pockets or a restoration issue. Could we perform full periodontal probing charting, assess radiographs for bone loss, and consider scaling/root planing with pockets are greater than or equal to 4 millimeters? I'm tracking subjective breath intensity and bleeding events in a log that I have brought. For the ENT, I performed oral self-checks and a 48-hour trial without significant improvement. I have persistent posterior nasal drip, frequent throat clearing, and ongoing perception of bad breath despite tongue care and saline gargles. Could you evaluate me for chronic rhinosinusitis or allergic rhinitis with nasal endoscopy and advise on imaging if indicated? I'm keeping a symptom log including nasal discharge, throat clearing frequency, and subjective breath scores. For the PCP, my bad breath persists despite improved oral care. I have dry mouth that I suspect may be medication-related and occasional reflux symptoms. I'd like a medication review for dry mouth contributors and to discuss basic labs or referrals if you think systemic causes should be considered. I have a 48-hour/2-week symptom log to share. When you bring these scripts, also bring your log. A simple log template you can use. Date/time, subjective breath score 0 to 5, tongue coating none, thin, thick, gauze/floss smell none, mild, strong, plus blood present, yes, no, tonsil stones visible, yes, no, nasal symptoms, none, congestion, postnasal drip, purulent discharge, other notes, meds, sleep, diet, caffeine, tobacco. That log gives clinicians immediate, usable data. Below are clear red flags that require prompt or urgent medical attention. Do not delay contacting a clinician. Rapidly worsening facial swelling, severe facial pain, or visual changes, possible orbital or deeper infection. High fever with facial pain and purulent nasal drainage with worsening symptoms despite home measures, possible acute bacterial sinus complication. Difficulty breathing, stridor, or inability to swallow saliva, potential airway compromise. Heavy or persistent bleeding in the mouth or throat after attempted self-extraction of a tonsil stone, seek urgent care. Sudden unexplained systemic symptoms alongside bad breath, significant weight loss, jaundice, severe fatigue, or changes in urine output.
Now, a practical frequently asked questions segment. Concise answers to questions patients commonly ask. Can my gums alone cause bad breath? Yes. Periodontal pockets harbor anaerobic bacteria that produce VSCs. If you have bleeding on floss or persistent odor localized to areas around certain teeth, periodontal disease is a likely driver and usually requires professional care. Will mouthwash fix it? Mouthwash can temporarily reduce planktonic bacteria and freshen breath, but often does not reach deeper reservoirs, like periodontal pockets, tonsil crypts, or sinuses. Use alcohol-free formulations if you have dry mouth, and avoid prolonged, unsupervised use of strong antiseptics that can alter the microbiome. Are tonsil stones dangerous? Most tonsil stones are benign, but can be bothersome due to odor, gagging, or foreign body sensation. Conservative care is safe and effective for many. Avoid sharp home extractions. Seek ENT evaluation for recurrent, large, or symptomatic stones. How long until I know whether the sinuses are the problem? If your oral checks are negative and you have clear nasal symptoms, chronic congestion, postnasal drip, purulent discharge, an ENT assessment is reasonable after the initial 48-hour trial, or sooner if symptoms are significant. Medical therapy may show improvement within days to weeks. Structural problems require ENT diagnostics and sometimes procedures, which have longer timelines. Can diet cause bad breath? Yes. Low-carb diets can cause ketosis with characteristic breath odor. High-protein diets increase substrate for odor-producing bacteria. Also, strong-smelling foods, garlic, onion, temporarily affect breath. Managing diet and hydration helps but won't fix non-dietary reservoirs. Does reflux cause bad breath? GERD can expose the oropharynx to gastric contents and change local pH and bacterial communities, contributing to bad taste and possibly odor. Treating reflux under PCP or gastroenterology guidance can help when reflux is a significant contributor. Now, for production and your hands-on demo team, a step-by-step transcript you can read or display on screen when you film the practical checks and the 48-hour routine. This transcript avoids prescriptive or risky instructions and focuses on safe hygienic technique. Step-by-step demo transcript, suitable to narrate while showing close-up visuals. Start with hygiene and tools. Use clean hands or gloves and a sanitized tongue scraper or the back edge of a clean spoon. Have a small tissue or disposable container ready for the scraped material. Use a single piece of sterile gauze and an extra piece of floss for the gum line test. Use a small flashlight or mirror with light for the tonsil check. For nasal irrigation demos, show the device and the label. Use distilled or boiled and cooled water only. Tongue scrape demonstration. Stand in front of a bright mirror. Extend your tongue comfortably.
Place the scraper near the back third of your tongue. You do not need to reach deep into your throat. Gently pull forward, applying light pressure. Wipe the scraper on the tissue and repeat 1 to 2 times. Sniff cautiously from a short distance. Record odor intensity. Rinse the scraper and repeat gently in the evening. Gauze/floss test. Take sterile gauze or unwaxed floss. Gently rub along the gum line of your back molars for several strokes. Do not push forcefully into pockets. Bring the gauze or the floss close and smell briefly from a short distance. Note any odor and whether you see blood on the gauze or floss. Dispose of used materials hygienically. Mirror tonsil check. Stand in a well-lit room, tilt your head forward, open widely, and say "ah" to lower the tongue. Use a flashlight or the mirror's light to look into the throat. If you see white or yellow pebbles lodged in tonsil crypts, note their size and whether there are multiple stones. Do not attempt to remove them with fingers, toothpicks, or sharp tools. Saline gargle demo. Dissolve about half a teaspoon of salt in 8 ounces of warm water for a simple saline gargle. Take a mouthful, tilt your head back slightly, swish, and gargle at the back of the throat for 15 to 20 seconds, then spit. Repeat twice daily or after meals. If you have heart conditions or dietary sodium restrictions, check with your clinician. Nasal irrigation demo. Show device and instructions read aloud without dosing. Use the device according to manufacturer instructions. Fill with distilled or boiled and cooled water and saline solution per product labeling. Lean over a sink, tilt your head according to the device guidance, and gently irrigate one nostril at a time. If you experience severe pain or ear fullness, stop and consult a clinician. Xylitol gum and saliva stimulation. Chew sugar-free xylitol gum for about 5 to 10 minutes after meals if tolerated. This simulates saliva flow and helps clear loose debris. Logging demo. Show a mock log and fill in one entry: date, time, subjective breath score, tongue coating description, gauze smell, bleeding, tonsil stones, and nasal symptoms. Keep this log and bring it to appointments. Remember to show clean hands, disposable tissues, and sterile materials. Do not show or instruct forceful removal of stones with pointed tools. If demonstrating an in-office ENT removal, indicate that it is clinician performed, and do not provide a stepwise how-to beyond stating that ENT performs safe removal under direct visualization. To close the clinical content, here's an extended clinician FAQ tailored for dentists, ENTs, and PCPs. Short, factual lines you can use when preparing referrals or interprofessional notes. For dentists receiving a patient with possible ENT-related halitosis, patient completed a 48-hour oral sinus trial.
Tongue scraping provided minimal improvement, gauze or floss unremarkable, but the patient reports persistent posterior nasal drip and throat clearing. Recommend ENT referral for nasal endoscopy to evaluate for chronic rhinosinusitis or allergic rhinitis. Please note, avoid empiric systemic antibiotics without ENT assessment unless signs of acute bacterial sinusitis are present. For ENTs receiving a patient after a dental trial, patient reports negative oral checks after home 48-hour trial, but ongoing malodor and postnasal drip. Please perform nasal endoscopy and consider CT imaging if endoscopy demonstrates mucosal disease or anatomical obstruction. Correlate findings with symptom log and prior dental periodontal assessment. For PCPs, patient presents with persistent halitosis despite oral care. Review medication list for xerostomach agents, assess for reflux symptoms, and consider basic metabolic panel if systemic contributors are suspected. Coordinate dental and ENT referrals as indicated by symptom distribution. Finally, a practical 2-week plan to follow if your 48-hour trial produced an ambiguous signal and you want an extended, carefully measured attempt before referral. 2-week targeted plan. Morning, thorough toothbrushing with fluoride toothpaste, tongue brushing or scraping, flossing or interdental brush once daily, saline gargle after breakfast. Midday, after meals, rinse with water. Chew sugar-free xylitol gum for saliva stimulation if tolerated. Evening, repeat morning routine. Consider once daily alcohol-free mouthwash if tolerated, short-term use. Saline gargle before bedtime. Daily, 1 saline nasal irrigation if you have nasal symptoms. Hydrate throughout the day. Avoid smoking and minimize alcohol the first 2 weeks. Record daily entries in your log: breath score, tongue coating, gauze or floss smell, tonsil stones, nasal symptoms. After 2 weeks, review the log. If breath and objective measures have clearly improved, continue maintenance. If persistent, use the clinician scripts above and schedule appropriate referrals. If oral tests point to periodontal disease, prioritize dental care. If nasal symptoms dominate, prioritize ENT. A few closing practical tips that often make a difference. Nighttime dryness is a common culprit. Address mouth breathing and sleeping environment, humidifier use, and discuss medication-induced xerostomia with your clinician. Avoid high sugar or high protein late-night snacks that provide substrate for anaerobes while saliva flow is low. Tobacco use worsens odor and impairs healing. Cessation support is clinically beneficial. Keep expectations realistic for deeper disease. Periodontal therapy and ENT interventions often improve breath over time rather than instantly.
To recap briefly, chronic sinusitis and rhinitis are common, often missed contributors to persistent bad breath,
because they seed the posterior airway with protein-rich mucus that nourishes odor-producing bacteria. The 3 quick self-checks, tongue scrape, gauze floss test, and mirror tonsil inspection, paired with a 48-hour trial and, if needed, a focused 2-week plan, will give you actionable information to triage appropriately between dental, periodontal, ENT, and primary care pathways. Document carefully, use the clinician scripts to facilitate efficient visits, and escalate according to the decision ladder we covered. If you've watched this far and are ready to try the hands-on demo we referenced earlier for the safe demonstrations and visual close-ups, that step-by-step film is linked in the description below. If your odor persists despite following the 48-hour and 2-week routines, please use the clinician scripts in the description to schedule appointments with the appropriate provider, dentist, periodontist, ENT, or your PCP, and bring your symptom log. Persistent halitosis is not a personal failing. It's usually a solvable clinical problem once the true reservoir is identified and treated. You're not alone, and with a methodical approach, most people see meaningful improvement. Thank you for taking a careful, evidence-framed approach to this issue. If you found this helpful, please use the clinician scripts in the description, schedule the appropriate evaluation if needed, and consider sharing this video with someone who might benefit.